Please go.
Okay. Good evening, everybody. We are very happy to host David Napier from the University College of London this evening. It's the almost last seminar of our webinar on the anthropological perspective on COVID pandemic, a global perspective, and it is a great pleasure to have Great Britain represented in this webinar. We have tried to cover most parts of the world, and we have not succeeded, obviously, to cover the whole of it. But Professor Napier has also been very generous because he already published some documents, some articles on the topic, Rethinking Vulnerability Through COVID-19, published on number 36 of Anthropology Today, and then I heard it through the grapevine on herd immunity and why it is important. So he shared with us generously his two texts. We already sent them to our associates, but I think that they're very easily readable on the internet. So please, if you don't have received them yet, you can access the sites of these journals to read them. But in any case, he's going to give us his conference today on assessing vulnerability in COVID-19 strategic methods, and we are very eager to listen to him. But before I want to leave the platform to my friend and colleague Giovanni Pizza, who will be the host today and who will moderate the discussion. I ask all of the participants to please shut off their cameras and microphones in order not to disturb the recording. And then when the first part of the conference will be finished, then we will open the discussion, and they may book their intervention on the chat, or if they wish, open the microphone and intervene with their questions. Thank you very much, Professor Napier, to be with us. We are very eager to listen to you. Giovanni Pizza, you have the floor, and switch off my microphone.
Thank you very much. Thank you very much to Alessandro Lupo, and welcome to everybody for having coming here to this conference, Zoom conference of the Società Italiana di Antropologia Medica. And thank you above all to Professor David Napier, who is here with us after having sent, as Alessandro recalled us, two witnesses of his engagement in this period of pandemics. So it is very interesting to have you here, and I have to say that Professor Napier is really one of the most influential medical anthropologists all over Europe and in contemporary medical anthropology all over the world. And I am fascinated by such an medical anthropology made by David, because it is an anthropology which at the same time is theoretically engaged and really very specific on the ethnographic description. That is why, for instance, he wrote so many stuffs. That is, he wrote many books, many articles, many review articles. He received many awards. I cannot say, but anyway, for that, I just want to recall that he is the director of the Center of Science, Medicine and Society. That is a network about which maybe he will tell some other things, but it is a very important network based on the transdisciplinarity, the interdisciplinarity, I don't know, how do you say in English, this idea of consilience, which is very important for medical anthropology today. We must be engaged in practicing consilience. And that is the reason why we look at your anthropology, David, as a model for us in Italy. And that is why we are very glad to have you here now. So I give the word to Mr. David Napier for his talk to this conference seminar of Società Italiana di Antropologia Medica. Thank you very much. Grazie.
Thank you very much, Giovanni. Everyone, it's a great pleasure to be here, and let's hope that the internet holds up okay and that I'm able to find my way through the following presentation. As I said, my topic is assessing vulnerability in COVID-19, and I want to talk about strategic methods. Before I begin, I should say that I should declare my memberships and interests. I won't talk about these, but just to say that I have been involved in assessing vulnerability in a variety of contexts, and I'm happy to talk about any of them. However, today what I want to do is I want to spend a good part of my talk, first of all, discussing what vulnerability actually is. And then towards the end of the talk, and time provided, I want to talk specifically about how to assess it, as Giovanni said, to try to make the transition between the theoretical concerns, which I'll bring up in the first part, and then the actual application of that. And of course, I will be talking about COVID-19 intermittently throughout the first presentation. What I'd like to do, therefore, in this first part is to discuss what vulnerability is. And I want to do that by providing 4 examples. One of these, the very first one, goes way back to 1990, 1994, when I worked with Robert Wood Johnson Foundation. Many of you may know that in the United States. They work a lot on community-based health. And I was commissioned by them through a grant to engage in community health assessments around the idea of setting up school-based clinics in rural and remote areas. And of course, we all appreciate that in contexts of crisis and in poverty, it's oftentimes the children who suffer most in these settings. What we did in this context was, over a period of those years, we worked on rural poverty in the United States and eventually elsewhere. And we're involved in 7 kinds of assessments. I won't read through the whole list, but you can see here that we were trying to get an idea within communities of not only who the people were who one could count upon to actually engage and to create innovations and potentially try to scale them, how that impacted teachers, students, nurses, doctors, and indeed policymakers, as well as the administrators themselves. Now, I want to start with this example of school-based clinics, is because it alerted us immediately to 3 very important dimensions of vulnerability, and I want to run through these very quickly. The first is, how do you survey those most vulnerable? Now, what I'm showing here is a picture of a child carrying a rucksack into his school, and you'll notice that, first of all, the school is, these are actually security forces. The kids have to go through a scanner even to get into the school. So the school itself is not necessarily for them a place of security. And of course, everybody, when we started this project, said, let's survey that group and let's survey that group. And of course, the problem with the surveying, sorry, I'm getting ahead of myself here. The problem with the surveying is that this very child who takes the survey home in his rucksack may bring it back the next day completely empty. That is to say that the very people you're trying to reach, you may not be able to because they don't have the capability, the opportunity, and the motivation that we normally associate with behavior change and with trying to affect behaviors within a community. So how do you survey those who are most vulnerable? It's an enormous challenge, and I'm going to get to this as we go through the rest of the PowerPoint. Okay, so with that in mind, what I'd like to do is I want to move to the next slide, which asks the question of, where do you find trust? Is it actually school-based? And of course, those of you who have teenagers in your family or remember being a teenager will recall that perhaps sometimes the last place you wanted to invest your trust was in school, because what goes around comes around, and students are often very apprehensive about teachers talking about them in the context of what's happening in that school setting. So where do you find trust? It's an enormous problem in understanding vulnerability. And then the third thing that has to do with rural poverty especially is, how do you survey people who have little or no opportunity to engage? Where do you actually get information from them? And this is particularly a problem in COVID-19, with the lockdowns that we're experiencing. And I'll say more about that as well when I get there. But the fact is that social isolation is an extraordinary problem. And in COVID-19, we see this just by one example within the framework of domestic violence and abuse, which has more than doubled during the COVID-19 lockdown. And of course, you think about the fact that this is emerging at the same time that everybody is telling us that we have to respect social distancing rules, without thinking about that many of these children for whom a school might be the only place where they get a good meal on a daily basis are returning oftentimes to extremely difficult circumstances. And I can say more about that in the discussion if you'd care to. But I wanted to start with this beginning study because it really alerted me, this is going back now, 30 years ago, to the real challenges of understanding vulnerability. So if the point being, the first lesson is if you want to understand vulnerability, you have to go out and find it. And this is, I think, an especially important thing for anthropologists to recognize and to build upon, because vulnerability is unlikely to step forward and represent itself. Oftentimes it can't, sometimes it doesn't want to, or it's too preoccupied with its own survival to see its vulnerability as the top thing on its list. And indeed, with COVID-19, and I'll talk about this in a bit, the actual disease may be 8 or 9 or 10 on the list of day-to-day concerns of some of the most vulnerable people, such as you see illustrated in this encounter in the image on this slide. So if you want to understand vulnerability, you have to go out and find it. I'm going to move on. The second example is one that followed that, and it was almost the work that I did right after that, from the early mid-1990s to around 2000. Indeed, I'm still somewhat involved with it, and I've worked with the homeless on and off, but that was the time during which I did my most intensive work with people who've really been neglected, and people who've really fallen into very, very difficult circumstances. And you'll remember at that time, those of you who are old enough and those of you who are young enough don't, and so I'm going to say something about it, that during this period, this was the time when Margaret Thatcher, the effects of Thatcherism, she was Prime Minister all the way through to 1990. She was a great admirer of Ronald Reagan and Reaganomics and the idea of redistributing national wealth to local authorities. Well, in some ways, that strategy works all right, doesn't it? I mean, this is fine when resources are abundant and there are surpluses to share. But what happens when decisions about community welfare are left solely to communities if those communities are themselves struggling? Because if resources become scarce and funds are reduced, so is the definition of what constitutes an insider. In other words, you start limiting that definition. Insiders become smaller and smaller and smaller. And, find in London that they'd go to this Westminster for healthcare, and they'd be turned away and told to go back to Glasgow or Norfolk or wherever it is that they supposedly came from on their migratory journeys to find their healthcare in a different place. In other words, the definition of insider gets reduced dramatically, and the concept of outsider, the othering of people, grows quite proportionally. And I'm going to say more about that in a while. But one of the things that really emerged in that context of that particular moment in history was how people were being alienated as resources dwindled. And indeed, we see this ongoing effect of inequality among vulnerable populations even today, much to the embarrassment of the British healthcare system and the British government. Even though we have a national healthcare system that's supposedly free to one and all, Doctors Without Borders still has its work in London, right? So the ongoing impact of those policies and their negative effects are really something that we need to think about in COVID-19. And of course, we see this kind of polarization in many countries across the globe. Can everyone hear me all right? There's a strange sound on my computer. Am I still online?
I'm hearing you.
And we listen to you perfectly. Go ahead.
Okay, excellent, great. That's good to hear. So the point that I want to make with this slide is that what we find in places where we already had inequality, mass inequality, is that we start to see regional governments in opposition to nations, whether they're states or provinces or cities. And I'm sure the experience in Italy in this regard may not be all that different from what we can observe at a distance in the United States. Cities versus governments, communities versus cities, neighborhoods versus cities, individuals versus communities. In other words, you see this balkanization or deterioration as trust is eroded. And indeed, in the USA, if you look at the Edelman Trust Barometer, which I show on the right, and this is just since 2017, all right, it's down 37%, and it was already in their previous trust barometer shown to be low in the United States, which you probably can't see on the slide, but it's the very last one, and it's followed by Italy just to the left, okay? So trust in government has a knock-on effect that's enduring and long-term, and we need to be thinking about the impact of that on the ground in terms of how people behave. And indeed, not long ago, well, this is now a year ago, there was an article in the Atlantic which states boldly, trust is collapsing in America when truth itself feels uncertain. How can a democracy be sustained? And I think that's a key question for us, is how is the concept of communal understanding and coherence? People talk about solidarity, but for many individuals, that rings hollow in the face of massive inequality, okay? So the first lesson from this second example, lesson point one, is if government does not take responsibility for health equity at the federal level, health outcomes will suffer. And of course, this is something that before we had neoliberal economics, John Maynard Keynes famously argued long ago in something he called the paradox of thrift. And what Keynes said was, when the economy slows down and demand falls short of supply, governments and universities, institutions in general, should not decrease their spending, but increase their deficits to make up for the lack of spending and the lack of ability from the private sector and the community sector. This is what he called the paradox of thrift. So in other words, we're where we actually undermine our ability to believe in one another at the very time when we need that most. This is obviously in the United States now in COVID-19. This is just the Washington Post from a few days ago. The survey found that 31% of African Americans know someone who has died of COVID-19, whereas the figure for whites is 9%, okay? Some very glaring evidence of inequality and also the bifurcation in the absence of collective trust. And indeed, most African Americans, the Black Lives Matter movement is actually building a lot of strength, not through what's happening in the United States, but what's happening in Rome and London and other places where they've been able to project their argument onto a global platform. Now, we can talk about that as well, but that there is very, very strong evidence for this. Whereas, if you look at here, we've got the Eurostats of levels of trust on the slide, half of the slide on the left, and you'll see as you go up towards the darker blue, Denmark, Copenhagen, Finland, Norway, Sweden, and so forth, the Netherlands to a certain extent, that the levels of trust are also the places where people, even when governments make mistakes, as was the case in Sweden, which was widely criticized, they're nonetheless maintained a certain level of trust in the government. And of course, again, if you look at trusted sources of COVID-19 information, and on the right-hand side, this is from Reuters, you can see that the largest people, the number of people you don't trust in maroon and red are people you don't know. And of course, that's followed very quickly by politicians, social media, and so forth. So the impact of those policies over time is really something that we need to take into account, because on the one hand, while many social welfare states are actually doing fairly well in terms of their management of COVID-19, where trust is not present, the evidence is fairly clear of the impact of that directly on the experience of inequality and of the illness. Now, this has another problem, and this is the second lesson, because only thinking locally, what does it do? It incites xenophobia. And remember Donald Trump's famous quote about migration before COVID-19, tremendous infectious diseases pouring across the border. The United States has become a dumping ground for Mexico and, in fact, for many other parts of the world. In other words, there's an absolute connection between countries in which inequality has already been present and the tendency of those leaders to scapegoat perceived outsiders, which, of course, in the United States now is not only people from other countries, but it's from people from other states. You may have noted that New York recently put a ban on people traveling to New York State without quarantine. If you come from Utah or Texas or Arizona, among others, you need to be in quarantine for 2 weeks or you're subject to a massive fine. I don't even know if that's constitutional, but they're doing it. So xenophobia is related to the practice, direct practice of othering. And here's an example from a place you wouldn't necessarily suspect that, or maybe you do, coming from Italy, being just next to Switzerland. But this, of course, is the Swiss People's Party, where you see the quite racist poster. I took this picture on a telephone booth in Switzerland about a year and a half ago, in which the exclusion of outsiders, perceived outsiders, is quite dramatically and grotesquely demonstrated. So the key question here is, to what extent is polarization itself a disease vector? Think about that. To what extent is political polarization a disease vector? The dissipation of community interest, of the common ground, and of our ability to deal with and attend to people who we take to be unlike ourselves, whether it's migrants or perceived foreigners, or whether it's just people who have different opinions. And of course, as you see in America, this political polarization has turned into radical fundamentalism on many different sides of the fence. And I pointed this out because in Hans-Jörg and Dominic's presentation a few days ago, I think it was Dominic that said that COVID-19 described as exposing the fault lines of our society. And I think for anthropologists, this is something that we really have to take to heart. So let me move on to my third example, which comes from Cyclone Nargis. Some of you may recall that on May 2nd, 2008, was the worst storm that hit the Gulf between India and Myanmar, resulting in 4 hours and 140,000 to 200,000 deaths. People don't know because there was no census at the time. More like 1 million people displaced, and about half of those people becoming homeless in a very short period of time. And I was asked by the United Nations, because of the previous vulnerability work, if I would help them conduct a vulnerability assessment. Those of you know that this is the Irrawaddy Delta in red, where the storm came through, leaving massive devastation. It's a high wall of water can do immense damage, even a 2-foot high wall of water under those circumstances. And of course, people who survived were just lucky enough to float in the right direction. The slide on the right is one that I took from a UN helicopter flying across the Delta. We flew for 6 hours in a helicopter, could only land twice. That is to say, there was only 2 places where it was sturdy enough and stable enough to land the helicopter. And what you see here is the remnants of what was once a road and a village, having now completely disappeared. So you'll also recall that at this time, Myanmar was ruled by a military dictatorship. The NGOs were all kept in the capital city, and it was only because the NGO with which I was working at the time, Merlin UK, had been there for many, many years, more than a decade, that we were able to get out into the field. And of course, part of the challenge here was trying to convince the very government that it was necessary to do this work. We did manage to do it, and we did a household survey that eventually covered some 13,000 people living in more than 3,700 households, I believe it was, somewhere under 4,000. But the problem was, of course, if you do a survey like that, it takes many months. And initially, they asked me if I would add questions to the household survey. And I said, look, if you can find vulnerable households, we can go out and start interviewing these people people immediately. And the question was then, and this is where my vulnerability assessment work really started to scale up, was how actually can you connect that qualitative data to quantitative data to these household surveys, which would take 3 months to complete before they were analyzed. We needed to get out quite quickly. So you'll see here they had 108 of these quadrants in which they divide. The red line is the path of the cyclone to tell you which of these were most severely hit. And it was quite a task actually to do this whole project. But because we were able to put a day filter, I won't go into the details of this, but the day filter essentially what it did was it would kick out as soon as somebody brought back a household survey. We could tell whether it met any of these criteria. This is the UNHCR criteria: households of malnourished children, children not attending school, reduced utilization of resources. Okay, female-headed households, households in which the care is under 18. I'm just skipping down to grandparents. Households where members are from different households. That is to say, they're not related by family. And with adolescent girls who are unrelated to the head of the household, okay? And out of this came the rapid assessment of vulnerable populations, which we hand out for free on our UCL website. But the reason I want to use this example, and you'll see the relevance to COVID-19 as I move ahead here, is that it wasn't just those standard case definitions in COVID-19 elderly and so forth. But what the survey allowed us to do was actually to come up with new case definitions. Now, we couldn't tell you until the 3 months work was done whether that new case definition represented 5 or 10 or 20 or 60% of the population, but we were eventually able to do that. However, we could tell you what the new case definition was. Here you see one of the camps that I visited for people who had been displaced because of the cyclone. And I won't go into the details here, but you can see there were a lot of problems using a global model of what a camp should be with an outhouse. In a delta means that people were just going out and defecating right in the very water behind their buildings. But the reason I wanted to show this slide was because you'll see something curious in the middle, which is a Buddhist temple being built, the first thing being built amidst all of this hardship. Now, why is that the case? Because historically, the Buddhist temples were the places where people tithed grain. That is to say, when you grew your rice, you gave a portion of that to the temple. And when the temple actually, when there was a crisis, the temple would distribute the rice in the community. Now, that's fine when times are stressed. It's not fine when you have a major disaster because the temples run out of grain pretty quickly. Now, this is compounded by the fact that there are one group of people who are not allowed into the temple, and that is women reaching puberty, okay, because they create chaos in the context of a monastery filled with a lot of young men. Now, what was interesting here is that what we're able to find out by doing the vulnerability assessment on the ground as anthropologists, most vulnerable groups, these are interviews carried out by women we trained in, actually this one I think comes from the very camp that I showed you the previous photograph of. What we're able to determine was that actually the most vulnerable group, more vulnerable than any of the United Nations categories, were young women reaching puberty. Why? Because they were asked to leave the temple. And of course, what we were answering at the same time was the very question of why Myanmar, as you see on the right, leads the world number of stateless people and in human trafficking. So this new case definition, which you will not, I promise you, find on any list of vulnerable populations, emerged as the most dominant one in that context. And that alerted me to the problem with ethnography. We can find these things, but we haven't really got the techniques for making them scalable. And that's what leads to the lesson here. First of all, what we have to recognize is that in times of instability, existing inequalities are going to be exaggerated, creating new case definitions. Okay, we must always remember that when we think we know in advance what vulnerability is and who is vulnerable, that's not necessarily always the case, because a crisis always creates these new definitions. And indeed, we see this as well in COVID-19, right? So everybody knows elderly people living with complicated conditions, diabetes, obesity, asthma, so on and so forth. We all know people who have say psychological disabilities and so forth. These are all known categories of vulnerability. Indeed, they're the very people that you always have time getting informed consent from, and because they're considered not to be able oftentimes to provide it. But the vulnerabilities we should have expected had we actually done this, and of course they're all obvious. Now they're obvious. Care facilities, prisons, hospitals, et cetera, even fancy apartment buildings in New York that have enclosed air systems because they're green buildings are a lot more vulnerable than your apartment or mine if you can open the windows. The unemployed, service employment, people who have to go out and work, people with no health benefits. What's it like in Georgia to be told that the COVID's over and you have to go back to work, for example? Living in a shared accommodation, as I've just mentioned, working in enclosed factories. There's a lot of stuff now. I was in the WHO meeting, which I'll talk about in a minute, yesterday and today. People in the meat packing business, people working with animals in enclosed spaces, healthcare providers, and the list goes on and on. Cruise ships, gyms, churches, etc. We all know now that these are vulnerabilities that we should have expected, but we somehow failed to. And that leads me to the fourth example. And that's the global biomedical establishment. Here's the pictures I took at the February 11th, 12th, 2020 WHO emergency meeting at which COVID-19 was named. And I'm showing this picture because it's not anything abnormal that you wouldn't otherwise expect of WHO, except for the interesting fact that on this occasion, they first of all had lots of social scientists, lots for having, I think, 600 people there, whatever it was, 300, I'm not sure. The numbers of people who were there personally or online, I think that the total for yesterday's meeting and today's was over 1,000. There were a handful of social scientists only who were involved in this event. And you'll see this just comes from the program from yesterday, the research roadmap. This was our second group meeting. At the acknowledgements on the left are the social scientists. We look like the largest group. Okay, so and indeed in every panel somebody mentioned the importance of the social sciences for COVID-19. However, you have to also recognize that this is a culture of biomedicine. So the social scientists make recommendations to the medical people, but we really don't have a place at the table, as it were. And this will happen over time. I mean, 5 years ago, you never would have had that social science group at all. So we are making progress, but we have to acknowledge that the challenges for anthropology, for any social science working in the field, are quite real. Everybody recognizes the need, but few people actually understand the potential significance. So we have key challenges here that, as a discipline, we need to face. First is the problem of medicalization, because we all know that in calamity coping, worrying about something you do not yet suffer from falls to the bottom of your list of needs. In fact, of WHO on February 11th and 12th, and about a third of the audience was nodding affirmatively, and I think the other 2/3 weren't very happy, because what I said was that for most of us here, COVID-19 the coronavirus, as it was then called, is the thing we've come for. But for the people we're concerned about, it may be 8th or 9th on their list, if it's on their list at all. And of course, what I was trying to point out was that in the absence of a vaccine, COVID-19 is only a social problem. Let's face it. Without a vaccine and outside of acute care settings, but even in acute care settings, you're treating pneumonia and other things. You're not treating COVID-19, are we? So that's one key problem. The other one is the problem of access, which becomes very obvious in emergency relief activities meetings. If you only react to disasters, you can no longer learn what you should already have known. You can't learn what you should have known. How do we study vulnerability if the most vulnerable are not reachable during a lockdown? Now, I'll give you an example of this. In Sonar Global, we have a project where we're in the process of doing vulnerability assessments for Central African Republic. Those of you who know the CAR know that this is not one of the easier places on earth to work as an anthropologist or indeed as a healthcare worker, working with UNICEF on this. And of course, in the lockdown, what happened was where we can't get our IRBs to give us permission to do face-to-face field work, even if we wanted to take that risk, which we wouldn't want to do, not only for our own sake, but for those of our subjects, but also those vulnerable people. And that gets back to the picture of the child I showed you from Appalachia in the first slide with the Robert Wood Johnson Foundation, which is why I wanted to show that we should know more about these things than we do. Those people in the CAR are now, you cannot contact them. And I can't tell you how many international meetings I'm on with UNICEF, with the WHO, with various the Red Cross, other organizations, in which people are complaining about the fact that they cannot identify or indeed communicate with vulnerable populations at all. And so if you want an example of the exacerbation of inequality in the context of a crisis, much to the embarrassment of all the emergency relief organizations, there you have it. So the fourth lesson here is emergency responses to a healthcare crisis have serious limitations. Because if you arrive late for the fire, to use that metaphor of the fire brigade answering a call, you can't find out what you should have known. You can't find it out. Because if you arrive late for the fire, your expression of concern may ring hollow also, like people saying, oh, solidarity, solidarity, and people in the street saying, I don't know what you're talking about. This doesn't, what solidarity are you talking about? And also, if you arrive late, as we showed with the example from the xenophobia, which I've written about and happy to share things about that as well, it incites you to blame outsiders in ways that are frankly not only unfair, but entirely grotesque. So how do you get around that? Well, here I'm showing a picture of vulnerability training that we fortunately were able to do as part of Sonar Global. This is in Kampala. The training took place in December of 2019 before Corona hit, and we were actually initially looking at Ebola and other highly infectious epidemic diseases that are endemic to the region. But as it turned out, and I think Young Soo, my postdoc, is in on this call, and I invite him to join us in the conversation to talk about the training. But as it turned out, we actually were training right before COVID-19 emerged, so that when our team went out to do their work, very much along the lines of what I've described from Myanmar, they've gathered as a pilot 100 1 to 3 hour assessments. So this is a lot of codable data on infectious disease outbreaks. And of course, what were people talking about? COVID-19. And I would submit to you, and I've written about this as well, that their work is probably the only face-to-face systematic study of COVID-19 in the field that we have. Because shortly after this, all of our ability to do work was suspended. Now, there's some lessons here about getting to this because in fact, I just had a piece with Ted Fisher from Vanderbilt today, and it came out today in Le Monde Diplomatique, and I'm happy to send it to you. But it is about the fact that you really need to get out before something happens. So it's not simply a question of just recovery or how we recover from COVID-19. It's a question of understanding the lessons about just preparedness and getting out at a time when you actually can learn about something which, when the fire happens, you're very unlikely to find something about. So allow me to make some generalizations about vulnerability, and then I'm going to go on and I'll use my last 15 minutes to talk about the assessment. So as a kind of a summary, vulnerability, like resilience, is not a fixed state. Rather, it's dependent on the local, regional, and national contexts in which it emerges. It varies locally, therefore understanding emerging case definitions is really critical. And these are complex case definitions. They're not amenable to randomized control trials because we know that these risk factors compound one another. They compound one another, to use that syndemic language of Merrill Singer. Those living under stress can quickly slip into vulnerability, making behavior change impossible. So all of the government initiatives on behavior change, they're going to have an effect on people who have capability and opportunity and motivation. but they're not going to have much effect on that kid, to get back to my first example, who takes the survey home to the trailer in which he lives in poverty with his family and comes back to school the next day with no information. Less vulnerable, life is characterized by calamity coping, not by concerns about disease prevention or health promotion. Not by concerns about disease prevention or health promotion. So for the WHO, until they realize that many of the people that they're trying to have an impact on are not thinking about what they're thinking about, their chances of having a significant impact are really quite limited. These facts make it our duty as anthropologists to identify and make public these new case definitions of vulnerability in order to show how they come to life in a crisis, how people get pushed from a state of living on the margins, just getting by, into calamity coping, where they're not able to actually affect their own health destiny, to show why the bottom-up perspective is critical. Sorry, I skipped the slide there. To show how these case definitions can be made scalable, and I'll talk about that in a minute, and to show why it's important to focus on preparedness rather than only on emergency responses. Guardian 2 days ago, at the level of preparedness, pointed out that only 6% of the UK public wants to return to the pre-pandemic economy. So why don't we think about this as the cup half full rather than the cup half empty? Think about the opportunity that it has for our discipline actually to improve its ability to engage local citizens and advance the health and well-being by addressing their needs. So just recovery matters, but just preparedness matters more. Okay? But we can't engage in just preparedness if we aren't actually interested in defining these case definitions before a crisis and understanding why it is that young girls reaching puberty are still the most vulnerable people in Myanmar to this day. All right. Now, I don't have a lot of time left, but it looks, we started at 5 after, so I think I should be able to get through some of the details of how we go about assessing vulnerability. Here's the same manual. It's available on the Sonar Global website. You can download it. There's a cautionary warning on the website, which is to say it's a guide. It is not an assessment. Assessments are typically significantly much more detailed than this, but it does describe the structure that I'm going to describe right now in some more detail than I'm able to do in 15 minutes. And therefore, if you are interested in following up, please download it and get back to me if you like. So what we did with the vulnerability assessment is this is not an inventory of simple questions. Because what we're trying to do is understand those structural problems that I've been talking about for the last 35 minutes. And the assessment itself is divided into 3 parts. And I know this seems like a detail, but it's important to understand why it's divided into 3 parts. The first part's the service domain. And of course, a lot of us do work about service utilization, who uses a service, who doesn't, who gets left out. Is it or long-term? Is this no of coping? Is it calamity coping? Is there state welfare? Isn't there? These are all typical things that we all need to know about. They're what my colleague and friend Michael Marmot writes about in The Social Determinants of Health, and they're extremely important. But they're only the tip of the iceberg from the standpoint of anthropology, because we know that social services are often lacking. And when social services are lacking, who picks up the responsibility? It's the community level. We call this social capital or cultural capital. So the second part of the assessment assesses that very thing. Who are the people in a community who actually people trust? Who actually has an interest in sustaining community integration? What kinds of adaptations are being made in the absence of formal services? Are they pathological or are they enhancing? And people don't realize that a lot of adjustments are gangs are actually a form of social cohesion in the absence of other forms of political cohesion and social trust. So the community domain is important because it helps us to understand better what everybody is clamoring about in these disasters, which is how do we get so-called community leaders to talk to governments and so on and so forth. However, That's not the whole picture, because you also then have the vulnerability domain, because if communities become unequal in these contexts, what do you do? So let me just run through this very quickly. So the formal domain, just to reiterate that overview, is we're trying to get a sense of utilization patterns and the kind of assistance and whether needs are met or not met, and whether there's equality of access. Now, you may think, well, this is something easily quantifiable and most public health data should carry it. It's not the case, because equality of access is oftentimes surprising. And you know, as an ethnographer, that oftentimes we've sat in houses in Mexico and people will say to us, yes, we all have health insurance. And the wife who's not being interviewed yells from the kitchen, I don't. So actually understanding and taking ethnographic observations around that understanding are really important for getting a sense of what the real utilization patterns are. They may not be scalable. We'll talk about that in a minute, but we need to know about service utilization. Now, I want to bring up an unrelated example of this, because as you may have noted at the beginning, I'm a global academic lead for Cities Changing Diabetes. And this is not a calamity coping setting at all. In fact, it's called a disaster in slow motion. But why I want to bring this up is because in diabetes, you have similar patterns of how illness is mediated by social practices. In diabetes, of the 430 million people worldwide who live with diabetes, if it were a country, it'd be the third largest country in the world. So it's a big problem. Only about half are diagnosed. Of those being diagnosed, only about half are in care. Of those only in care, only half achieve treatment targets. And of those, only about half achieve desired outcomes. So there are percentages here that vary a lot, and we do a rule of halves analysis in a particular that achieve desired outcomes is 1% or 30. Now, if you think about the fact we know the number of people with diabetes, if you go to COVID-19, the diagnostic rate is possibly as low as 1 in 10,000 people project. I've heard this just yesterday again. Just knowing what the numbers are here is almost impossible. But because if you look at it in terms of what these domain tells us, this middle part, the biosocial domain, most of the rule of halves is about adherence to clinical treatment. So we call it biosocial because it's how biology is mediated by cultural and social practices. Above that, the people who are undiagnosed, their experience is only social and cultural. They don't even know they have diabetes. So you can't say that their experience of the illness is biological, because it isn't at this point, okay? It's only that very bottom domain, which is a very small percentage of diabetes. As I said, that may be 3%, or in Indonesia, it might be 3%. Even in a welfare state like the UK, it's only going to be 30 to 40% on a good day, where the experience of the illness isn't mediated. If you had the one single risk factor for diabetes, obesity, that biomedical domain becomes a thin line drawn through a desert of ignorance. Now, if you go back to the other side and you realize the diagnostic issues in COVID-19, you'll realize that the level at which we can describe COVID-19 as a biological problem rather than a social problem, or in addition to being a purely biological problem, is even smaller still. It's even smaller still. Okay, so the community domain becomes really important, because that's where social activity happens and where we engage it. And as you see in this section, we ask about community cooperation. We ask about customary rules, if they're adapted, if they're transformed, if they're ruined, if they actually are helpful. The duration, are there new forms, things like citizen science and so forth. Again, about inequality and sustainability. Can they be scaled up and grown? Can we learn something from them positive? And of course, this is important because how discussions about governments working with communities on health issues, this is a key feature of vulnerability. And this means in times of stress, these inequalities do get exaggerated and these new vulnerabilities emerge. So when people talk about, oh, we're going to talk to community leaders, anybody who's done fieldwork in a hardship, the problem of vulnerable populations. Because if you're a community leader, oftentimes the last thing you want to do is acknowledge the gross inequality that you yourself represent, because you have voice and others in your community don't. And this is something that we need to bear in mind when you think about organizations like the WHO, which is basically paid for 30% of its funding by member states, where it actually has to go through those channels in order to get to local populations. So anthropology here becomes exceedingly important in terms of understanding vulnerability. And this is really made clear when you look at the European Policy Health Impact Assessment. I'm not going to spend time with this, but this is how we're supposed to be doing health impact assessments, just to give you an idea. And I don't want to spend a lot of time looking at this, but if you go to the right-hand column and you go through screening also on the left, and then you come down to policy analysis, profiling of communities, qualitative and quantitative data, impact analysis, recommendations, and process of health. Now, what's missing here in what I just talked about in this slide, what's missing here is this. Okay? We're going to do qualitative and quantitative data collection, but nobody's talking about this exacerbation of inequality that's a part of any crisis, okay? Which we experience even in our countries when we see politicians looking out for their own financial and health interests and then voting against policies that are there to help the poor, like many conservatives, congressmen in the United States who are on leave from Congress for hundreds of thousands of dollars while voting against policies that would provide healthcare benefits for the poorest population. So this is really a flaw that anthropology needs to become much more engaged in. And then we get to the vulnerability domain, because this does a couple of interesting things. When we actually get out into the field and do an assessment, one of the things that we do is we not only look at who suffers and describe it in the way that I did for Myanmar and the young women reaching puberty ending up in trafficking, but we also do one other thing that's really only anthropologists can do, or that is to say, only people working in the field can do. And that is, we ask the person we're talking to, who we know is vulnerable by one of those case definitions that gets thrown out of our quantitative health assessment that we're doing, the household surveys. We know they're vulnerable by some global standard. We ask that person, who's more vulnerable than you? In other words, we want to find the person who has no capability, opportunity, and motivation. And then we ask if they can show us that person or take us to them. We want to talk to that person. Why? Because that's the person who knows what the barriers are to actually being the advocate for your own health destiny. What is it that keeps them from engaging in anything other than calamity coping? And this is something that no survey, no analysis of large-scale quantitative data sets is going to tell you about. The only way you're going to find this out is through ethnography, and through structured ethnography that then allows you to scale that case definition to other evidence. And I'll talk a little bit now about how we do that. So the problem of how we respond to chaos, which it can be posed as a question, which is, why is it so much of our concern over human behavior and pandemic outbreaks focused on maintaining order rather than on understanding vulnerability? That is, on how people are made vulnerable by disorder and on what can be done to redress, that is to say, to attend to the heightened inequality that disorder gives rise to. Who's left out? This is the big question. How do we find out who's left out? How do we understand what the barriers are? How do we describe them so that somebody isn't just saying, oh, that's a Save the Children poster. Yes, they're playing on our sympathies and say, no, that's actually 30% of young women in Myanmar, or 20 or 80%. Right? And the way we do that is, first of all, we code our data. So these assessments that go from 1 to 3 hours, we actually code them by, this is a typical example, in which we're looking at biological, social, geographical, cultural factors. And of course, what you can do is you can draw lines across this any way you want to come up with a case definition. You can show any connection. You can go up and down these. But the point being that these characteristics are going to coalesce around groupings. All right. Now, the point is that we all know that this is important. Policies framework, which everybody talks about, but few know how to do anything about, has been going on about, that you need to understand how people become vulnerable in housing contexts, water and transportation, water and sanitation, transportation, occupational. And of course, I could be blipping each one of these blue rectangles and showing a COVID-19 part of this, you can look at them and think, oh yeah, that's an easy one for COVID-19. I can think of several of them. But the point is, to go back to this slide, it's the way they work together. This isn't about, I listened to somebody complaining about how they were trying to do a randomized control trial around the difference between washing your hands and wearing face masks. Well, you can't do that. You can't do that because the experience of living is mediated by all of these other factors. And of course, one of the things is that we know that these new technologies have been used for a long time now to monitor our purchasing habits, to invade our privacy, to try selling us stuff online by Apple and Facebook and all these other, or indeed Cambridge Analytica in elections, or people trolling, robots trolling, pretending to be advocates for candidates so they can disrupt the electoral processes and so forth. The fact of the matter is, all those technologies are pretty straightforward, and they can be used to our benefit as well. There is absolutely no reason that you can't quantify those case definitions. And indeed, this is something that that we're working on in Sonar Global right now for COVID-19 and for various other illnesses, including antimicrobial resistance and vaccine hesitancy, to name two. So the goal of conducting an assessment for COVID-19 is to try to find ways of extrapolating our findings. First of all, to map what these definitions are, to share them by scaling the definitions where we can. And of course, scaling them means the responsibility then falls to the people who do quantitative data and to find out. I mean, there are a lot of places in these health and health policies analyses where you just don't have data. Just the same when we do a rule of halves analysis for diabetes in cities around the world. We're now working with 20 cities representing, 30 cities rather, representing populations of more than 200 million people, the public health departments. And in those cases, you'd be surprised what is not yet known. But where you can scale them, you should try to do that, because this is the soundest way of trying to put your money to use where it can have the most impact in transforming your findings into concrete actions. So thus far, we've developed and implemented actually thousands of hours of vulnerability assessments around, these are some of the challenges that we worked on. I put vaccine hesitancy in parentheses because we're working on that assessment protocol right now. The others we've all done, at least antimicrobial resistance is happening, is being implemented as we speak in Bangladesh. The infectious disease I talked about, migrant health we've done here in Europe. NCDs, the cities changing diabetes, natural disasters is the Myanmar work. And I started with Robert Wood Johnson work. And to be honest with you, I haven't, as I think Giovanni pointed out in my introduction, I do have a theoretical interest in this. I've published a fair amount in public health journals. Our Science Medicine Society Network has organized 3 Lancet commissions, including the one on culture and health, which I led. So I'm not immune to that work, but there's a lot more that can be published with this data. There's a lot more that I think anthropologists can do and should be doing. And with that, I'll stop here. Thank you very much.
Thank you very much, David. Can you listen? Yes. Thank you very much for such an inspiring talk. I have to admit I am a bit astonished by so many inspiring suggestions coming from your talk. But anyway, I will make my first questions on the topic of such a protein-form concept of vulnerability. Since in your talk, it seemed to me, of course, maybe I am wrong, but it seemed to me that you yourself undermined our consciousness with this idea of surprise, for instance, our consciousness of medical anthropologists, in a sense that the crisis has undermined our traditional dictionary in medical anthropology. So how medical anthropology can enter this new field, can assess this vulnerability, which is in a sense unsayable thing. in a sense, on vulnerability. Vulnerability is critical in the sense that no government and no anthropologist can give an account of it. So how can we as intellectuals, as researchers, engaged both in ethnography and theoretical, as you are, as you showed us, so refined approach, how can we apply this approach in this moment after the pandemics? Maybe it's a question without answer, but anyway, it is what is first in my soul after your speech. Thank you. Of course, if there are any kind of suggestion, we can on the chat, and you can sign your name and express the desire to make a question to David. Thank you very much to everybody.
Thank you, Giovanni. And I will, since I don't see the chat, if you would just tell me when I should, you want to pose another question, please go ahead and do so. But in the meantime, you asked.
Don't care. Please talk.
You asked such a broad and important question that I'd love to talk about this. I think the first thing is that we have to think about a new kind of medical anthropology, one where we don't have to apologize for being at the table. And indeed that we make ourselves indispensable, because there is no way of really understanding what happens to the most vulnerable populations unless one is able to get out there and understand what the barriers are to people being able to engage in the kinds of recommendations that governments and healthcare authorities are making. And we can all think of somebody in COVID-19 who's had this kind of a problem where they just simply are not able to, they're not able to act. And indeed, the embarrassing part about this, and this is where I think in terms of future preparedness, where we really have to campaign for this, is that all these things could have been readily understood beforehand. There's not one of those categories of vulnerability that emerged in COVID-19 that we couldn't have thought of earlier if we thought about what's going to happen when there's a viral pandemic. People have been talking about this for a very, very long time. And so I think that it's our obligation to get involved in the conversation and not to be dismissed by people who do want to medicalize this. I'm the first one to say that if there's a vaccine, I sure want to get it when I can. And I'm the first one to say that as soon as we have a vaccine, this does become a medical issue. Absolutely. That becomes our highest priority. But that's not what's happening now. That's not what's happening now. And indeed, what we hear are medical doctors largely telling us about why don't we have more data about the social sciences? Of course, all you have to do is go to the funding agencies and see why we don't have more to say, because we're very much at the bottom of what's being given out. Let me give you an example. At the February 11th and 12th meeting, at the final session where I made the comment that I pointed out in my talk, I was quiet for 2 days. I mean, one doesn't easily raise your hand in an auditorium with several hundred people as a social scientist, knowing that they're all bench scientists and medical doctors and public health people. But in that last section, it was about funding, and it was the funders forum, and the Gates Foundation representative very wonderfully stood up and said, Bill Gates has now given his largest donation ever. He's committed $100 million US dollars to COVID-19. 60 million of that will go to vaccine development, 20 million of that will go to public health, and 20 million of that will go to vulnerable populations. And as soon as he said that, I raised my hand because I knew how they define vulnerability. It's unvaccinated, right? That's vulnerable, right? And I said, I just wanted to get it on record that the social sciences were important there. And I said, thank you so much for talking about vulnerability. And that's where I made the point about COVID, the coronavirus, and being 8th or 9th or 10th on people's lists, because I wanted to point. It's a social problem. And it's a social problem about which we could have known much more than we do. in which we can know more than we do. So I'm not just criticizing people. I'm saying, hey, this is a wonderful opportunity for anthropology. Unless is there another question there? Because there isn't, I'll give you another example. I think you're on mute, Giovanni. Giovanni? I can't hear you.
Sorry, excuse me, but I'm not so keen on
It's
this
all right.
kind of...
Same problem.
Well, there are three more questions. One from Francesco Vacchiano, one from Claudia Merli, and one from Alessandro Lupo. Now I give the word to Francesco Vacchiano.
Thank you.
Thank you.
Thank you, David. It's very stimulating your presentation and your suggestions, actually, in terms of methodology and reflections, etc. I was very much interested in I mean, you mentioned the 3 steps of your approach, which is mapping, sharing, and acting. And I'm very much interested in what you could say to us in terms of acting, because I agree that vulnerability assessment is fundamental, and actually it confirms your methodology, the methodology you propose. Many assumptions, I mean, not assumptions, but many ideas of medical anthropology about the importance of considering society, welfare states as important intervening factors in structural violence, in possibilities to increase the vulnerability of some specific populations. For example, I have an experience, I mean, in Lisbon, where with a group of colleagues have been warning about the vulnerability of asylum seekers hosted in very worn out facilities, overcrowded places. And I mean, it was clear from the beginning that these were a particular group, because of their condition of reception, very much neglected. And actually, I mean, after 3 weeks, it came up on all newspapers that this group was one of the most affected by contagion. I mean, and we were able in advance to identify them as a vulnerable group due to their condition of instability, precariousness, hosting conditions, etc. But when it comes to policymakers, I mean, that's the point. I mean, I'm sorry to repeat a point we have already risen 1 week ago with Arthur Kleinman. I mean, when it comes, I mean, we are aware of this and we can do this assessment, but when it comes to policymakers, it seems very much the reasons and priorities are all others. I mean, so how can we put vulnerability assessment with acting in good practice, in a condition of good practice and possibility to interact between all actors, and especially policymakers? Thank you very much.
Francesco, thank you very much. It's a wonderful question, and I much enjoyed listening to your own experiences. And please come back if I'm not clear on my response. I entirely understand what you're saying about policy, but I think there are a couple of elements here. One is, first of all, it's important to get people on board at the policy level at the beginning, and we found this that especially in the larger scale work, like the Cities Changing Diabetes Project, which has now been going for, we're in our 6th year doing that. And we have an academic network of about 120 people, but we never do a project unless we have policymakers who express interest in the beginning, so that when we get to the action phase, we haven't left people out of the conversation. Now, as for convincing them, what's really interesting is, and this is a strength of anthropology, if you're working at the local level, it means that, I mean, for example, take the group C40, the climate change health mayors, right? There are, I don't know how many of them now, 90 some cities that have signed on for addressing climate change where governments won't. City mayors. These are all people who have an enhanced responsibility to local populations. And those avenues are ways in which anthropologists actually can get more closely engaged with the people who are making those decisions. And of course, what you can also do is you can talk to them in concrete financial terms, because if you understand, I mean, think about all the criticism of emergency aid and how it's wasted. All the books that have been written as critiques of organizations that, you know, the problems of bribery and corruption and funds disappearing and, you know, all the rest of it, and people misusing antiretrovirals and giving them to chickens to fatten them for market, all those sorts of things that drive people away from supporting those really important global initiatives. If you can show that you actually can streamline those interventions and save money by understanding who's vulnerable locally and what drives vulnerability, then people will listen to you. In my experience of that, let me give you an example. In Houston, Texas, if you look at social capital maps of the United States, Texas is pretty low on the level of social capital, right? Okay, so when we did the vulnerability assessment there, this was for diabetes. What we found out was that the people who were vulnerable, there were the known suspects. There were African Americans living in a food desert with multiple comorbidities, single parents, HIV positive, all those sorts of problems that people have to live with. We had Latinos who were migrants who wouldn't come to a hospital and presented very late because they didn't want to be identified, right? So they're already going blind before they even show up for to get any kind of care. But what we found was there's another group that nobody had been looking at. In fact, the director of public health for Houston said, I think I ought to go back and take another degree after we did this research, because it was middle-class people living in the suburb who are well-educated. Because the most wealthy of them, as Houston grows very big, live farther and farther away. They spend anywhere between 2 and 3.5 hours in their car every day. They live in gated communities. They eat every meal out. They have no time for exercise. And the only time they actually can eat together is on weekends. And what do? They feast with their families. They feast. They don't fast. They feast. So by identifying these new case definitions, we were able to actually to have an impact that we weren't aware of.
I'm having it right now.
Also, we identified the fact that in the absence of social capital, local churches were really the most trusted place for people to get health advice. And so working with religious organizations had an important impact on people's willingness to accept healthcare advice, and indeed to take action around the complex problems that people would live with, non-communicable diseases. Just to summarize quickly, if we can start to think about what's happening on the ground, your comment about containment and migrants, you know, if you think about containment as a cultural category, it really helps, because then you've got migrants who are in detention, you've got people in prisons, and you've also got very wealthy people in Manhattan living in high-rise apartments. I mean, why do you think Manhattan is having such a terrible time with COVID-19? You can't avoid touching things that other people are touching, right? It's just impossible. And so I think that these are areas where anthropology has always made a contribution, but I think collectively we need to make that statement more strongly at this time.
All right, so
clear. Thank you very much. Thank you, David. Thank you.
Well, thank you, David. And now the word is Alena Kameshikova from the Netherlands. Thank you, Alena. Alena?
Yeah. Do you hear me?
Yes. Yes, we can.
Yes.
You can make your question now to David. Thank you very much.
Yeah, thank you very much for this presentation. It was very...
No, I don't have my microphone on.
Sorry, do you hear me?
Yes, we hear very well.
Yeah, my question, I was quite curious when you also mentioned that currently the WHO level, at the international level, COVID-19 is classified more or less as the social problem. But what we also can see is this kind of movements towards finding a technical solution. So we have all kinds of IT companies, biomedical scientists, trying to find this one technical, scalable, universal solution that will work for the virus. So also kind of reclassifying it from social to biomedical problem. And we've seen it already with other infections and with other issues like antimicrobial resistance, where WHO published a global action plan, and it's been copied by many countries without much attuning to the local specificities. So I was wondering whether there is a risk which we can also anticipate of this potential slippery slope, where we go into the technical universal solution for COVID-19, where the sensitivity for local vulnerabilities and specificities are becoming very silent, and whether we can do something about it.
Thank you, Elena. I think it's a fascinating question, and again, one that we could spend a very long time talking about. Of course, clearly, the first issue is the way in which we fetishize technical solutions more generally. Clearly, we all, it's a new app on your cell phone. But of course, what our strength is in showing that those things can be of limited assistance for people who have, again, the ability to change their behaviors. So these apps work. And sometimes it's in surprising places. I mean, most of the homeless people I know in London don't have a home, but they have a mobile phone because that's their resource for getting food, finding out which shelters have extra beds tonight. In other words, it's the most critical part of their survival strategy. And so I'm the first person to say that those technologies can be useful. However, the problem that we're experiencing is that there's a great resistance to accepting the fact that nobody knows where to go for good information right now. Nobody. Okay. And so what recommendations are actually being made when the scientific community itself can't even tell us yet what we're in for in 3 months' time? We don't know. We don't know. I mean, it could disappear, or it could be the next round maybe to come. We just have no idea. And so the question of trust here gets very much devalued. We're not putting enough care into thinking about the relationship between human trust and what it takes for a person to take a risk, because all these things are risks, unless you just stay at home and keep the door shut and never go out at all. And so the question of how we engage one another in the face of what we're learning from COVID-19 is a critical one. The learning curve, in my view, is a very steep one. It's very steep because we're now being told that social isolation is a responsibility we have to one another, whereas we know that a way affection is effective is sitting face to face with one another and doing what you're doing right now, which is nodding, okay? Because that's a contract. And we make them thousands of times every day when we sit and talk to a person, and that's how we generate human trust. So if we're chasing people away from the very things that create trust, how can we expect them to trust in any of these things that are being invented for them? And then, of course, the other thing is that historically, that we've been very reticent about seeing these challenges as anything other than medical challenges. And what we have now is an opportunity to demonstrate that they're far more than that. And in fact, indeed, they're not medical challenges for most of us at this point, unless we happen to be in an acute care setting, or in another way, or find ourselves physically suffering as a result of it being immunocompromised or having complex other comorbidities.
Thank you very much both for the question and answer. Now the word to Claudia Merli from Sweden. Claudia.
Hello. Thank you.
Claudia.
Wonderful.
How are you?
It's always very inspiring listening to you. Okay, now I have a question about partly about trust, because you know that also in the graph you presented before, it was quite clear that certain countries, there is this very high idea of trust, and Sweden is one of those that always claim that there is a lot of trust between people and the state and people, between the people and themselves and so on. But that's not true, right? So it's like the whole idea of trust is a bit confusing here. So I remember just recently the NAPIER College of Bioethics published something about the difference between trust and trustworthiness. When I said something about the COVID-19, I was saying that there is a difference between trust and transparency. So it's not having transparency when communicating with the people, claiming that there is trust between citizens and the state is a bit problematic. For example, as you are addressing these new categories or case studies of vulnerability, I think it's quite remarkable that some categories of vulnerable people were identified very early on, not the elderly populations. Everybody knew these are the most vulnerable, these are absolutely the most vulnerable. And anyhow, they are those who were mostly affected in all different countries. Once the virus entered the elderly, the nursing homes, it was like a fire, they said. It was impossible to extinguish that. So I would ask you, what is, in your opinion, the relation between vulnerability and the definition of vulnerable population, and paradoxically, on the other hand, an idea of the state of complete invulnerability?
Your point, very interesting problem, and of course, one of the criticisms that's been made about welfare states is that the trust often is not accompanied by healthy skepticism, and the question of how citizens relate when they do place significant amounts of trust in abstract institutions that actually may induce them to go back more than think about changing the future. So one of the things I find quite interesting about especially about the community innovation part of this and what's happening with regionally in places where trust is not necessarily where it's dropped significantly, like the United States, is that oftentimes those innovations do take place in ways, and people do remember the suffering. They're going to remember the suffering much longer than are people who trust in states, the same way that African Americans are remembering much longer with the effects of race that are now being exposed, not just through police aggression and violence, but also through the mortality, morbidity rates of COVID-19, which we all know are much higher among African Americans. So there are learning lessons there, and the question is what do you do with them? So I think that's one. Thank you for your question, because there's one thing that it's a kind of a meta question, because the first big question is why, what is it about countries that allows them to ignore the needs of so many people and to come to the fire late and then to blame outsiders because you've been caught red-handed, never having cared about those vulnerable populations. So that's the big one for me. But the one you raised is also really quite interesting. And of course, I would never want to suggest that community innovation and leaving communities to themselves in the way Mrs. Thatcher did and the way Ronald Reagan did, okay, the whole Republican idea that regionalism and localism will prevail is the answer, because we all know that's the new Middle Ages. That just increases local inequalities because there is no, as it were, overall welfare to secure the health and the well-being of the population at large. It also, by the way, in my view, excuses people from having to engage with one another and potentially learning from one another. And to me, I think one of the biggest challenges of COVID-19 is the fact that containment, the legitimization of absolute containment from other people as a responsible social activity, has also relieved us from the extroverted risk that I would argue is just as important to collective social behavior as human beings, as is self-preservation. I mean, so there is that part of it as well, where I think your comment is really well taken. And then finally, I'll say that those statistics are generalizations, and of course, what they tell us as anthropologists is that those generalizations are categories of. Let me give you an example of this. Unless there's another question, since we do have a bit more time, I want to go into this. And Giovanni, interrupt me if there's somebody else waiting to talk. But if I could just respond to Claudia a bit more, I'd like to do that, because one of the things that we did.
We have half an hour.
Okay.
You have plenty of time. Go ahead.
Suppose there's nobody else waiting with a question. Let me respond to Claudia, because one of the things that we did with the information that we had on diabetes. Now, we're talking about thousands of hours of interviews of people living with diabetes from around the globe. That we are, in fact, it's certainly the largest data set of the lived experience of this disease anywhere. And we looked for statements that repeated over and over and over and over again, like diabetes is a death sentence, or diabetes is the hand of God, or whatever it may be. You can, I trust my care provider. I don't, I think I can live well without medical care. I stopped taking my insulin and I'm fine. Whatever it happens to be, we came up with a series of 60 some statements that repeated over and over and over and over and over again. And what we realized was that what we had before us was, as it were, the culture of diabetes, the way it's talked about, the way in COVID-19, the way we talk about viruses as invasive agents, as infectious disease, when in fact viruses are just information that are socially passed among us that we pass to one another. It's not, they don't actually, viruses don't have, they're not capable of reproduction. They're not active. Our cells bring life to viruses. So the culture of epidemics talks about them in the same way we would talk about a bacterial infection or anything else that's borne by a living organism. So these are cultures of cultures that we respond to variably, and so some of us will accept those statements and some won't. So in diabetes, what we've done is we put all those statements together in something called a Q sort. It's a methodological way of forced distribution. So you ask people whether they agree or they don't agree. So the statements constitute the culture of diabetes, because that is what comes up again and again and again. If you talk about diabetes, you got to use those terms. You've got to use those metaphors. If you study people like Mark Johnson and Lakoff, you understand that what these metaphors do is they embody those cultures of practice and those systems of value, which some people will agree with radically and some people disagree with. And what it allows you to do is it allows you to understand that there may be all these statements that people say that's not relevant to me. For example, in my case, I wouldn't necessarily think about the relationship between God and an illness that I have at this point, although I might think about it as spiritually somehow affected. But those statements are part of the knowledge base. Those experiences, whether it's diabetes or migration or COVID-19. Whatever it happens to be, and we can see that within that language, that you can actually identify various ways of going about pooling that information. And of course, this is what, to get to my end point about Facebook, this is exactly what they do every day. You know, when you go onto YouTube, they give you 10 other videos to watch on the side, and they monitor which ones you choose. And out of that, they start to characterize you in particular ways. And so those characterizations aren't going to tell you in any deep sense what the human experience is at the level of your specific emotional life, but they do give people a very strong sense of how groups of people can respond. And of course, this information can be used positively, but it also can become really quite dangerous, because it does show that even in places that, to get back to your beginning comment, that we would characterize, for example, as a welfare state, that there's going to be a lot of dissatisfaction within those contexts as well, among particular groups of people that somebody using that technology is going to identify. So sorry for the long answer, but I think it's a very, very good question. And thanks a lot, Claude. I hope to see you soon.
Thank you very much for both excellent, really. I would like to repeat that it is very inspiring, this kind of discussion. And now we have still 25 minutes for 2 questions and 2 answers. The first question is by Roberta Raffaetta, our colleague from Bolzano. Roberta, please. Roberta.
Yes, do you hear me?
Yes.
Hi, Roberta.
Yes. We don't see, but we hear.
Yeah, okay. So you see. So thank you very much, David, for the inspiring talk. And I would have a question of something you mentioned toward the end of your talk. And maybe you partly addressed that already in this last part of your answer to the previous question. So in that part of your talk, you said that there is a need for structured ethnography in order to have scalable results. And I totally agree that it's so important for us also to think through ways of making our results scalable if we want to collaborate with other disciplines and if we want to have a broader impact on the state of things. But on the other side, I think that is also might be a risky endeavor. So I wanted to know from your experience, what's the difference you found between conventional traditional ethnography and this more structured ethnography? Thank you.
Thanks a lot, Roberta. I think the biggest challenge to developing a structured ethnographic perspective is when you meet somebody interesting, you want to spend time talking about what they want to talk about. And so when I say structured, when we do the assessments, there are many open-ended questions, and we encourage people to explore them at length. So that typically, as I've mentioned before, they take anywhere from 1 to 3 hours to actually carry out. And indeed, some of the people become key informants that we will go back again and spend more time with later on. So I'm very sensitive to what you're saying. And one of the biggest challenges with doing these assessments, and part of the reason we actually don't publish much on them, is because as soon as you do that, and I found this to be the case in any of the vulnerability assessments we've carried out, people think that the assessment is just a list of questions. And so they'll read down the question of the inventory and they'll say, oh, I know about that, I don't need to ask that. Oh, I know about that, I don't need to ask that. Oh, this is important, and what about that? In other words, they'll cherry pick the questions based around their own assumptions. And of course, what we're trying to do is to minimalize that happening. It's just like with cultural competency discussions, where recommendations about cultural competency are oftentimes reduced to some really quite harmful stereotypes about doctors and nurses should do. And I would encourage anybody to, if you want a sobering example of what can go wrong, to have a look at those highly presumptuous, unhelpful, stigmatizing, and fundamentally quite useless recommendations that are made to healthcare providers that are based upon those stereotypes. So I'm incredibly in agreement with Roberta with your concern, and I think that there are a couple of things that we can do. The first thing is to realize that any kind of a structured assessment is only structured in some parts, and that it is not as specific. Everybody wants a quick fix. Can you tell me the 10 questions that will allow me to distribute this, because we don't have time to spend with other people? And of course, we have to resist that as social scientists. We must resist that tendency. But having said that, we also realize that if you're talking to policymakers and caregivers, they do want to know whether that particular case that you're talking about characterizes the experience of that person, and if in characterizing that, it also characterizes the experience of other people. And so the role of anthropologists is actually understanding the structure of culture is something that's really important. And it's something that, let's face it, that as anthropologists, our own discipline has worked against. You're not supposed to talk about culture, we're certainly not supposed to talk about structures of society. We're supposed to talk about lived experience and emotions and the everyday lives of people. And all those, I'm not being cynical about that. I'm the first to acknowledge that those things are very important. And I worked with Art Kleinman and Byron and Mary Jo and some people at Harvard for 6 years in their program. And I fully believe in the importance of that deeper ethnography on lived experience. But I don't think we should throw the baby out with the bathwater, because we do need to figure out where we're going to spend our money, don't we? And as that money gets scarcer and scarcer, we certainly think that it ought to be spent on the social sciences as much as on building apps for people, many of whom don't even have mobile phones, so or computers for that matter. And I think COVID-19 has demonstrated to us that anthropology actually can make a contribution. I'm speaking as a medical anthropologist, but of course I don't mean anthropology as a discipline that only people with PhDs in anthropology have. I mean the study of local practices and local systems of meaning, and the way that shared conventional understandings that, let's face it, we all use every day.
No.
How important they are, and to deny that, to only want to talk about the experience.
Non abbiamo scongelato la carne, Aro.
Sorry? I'm sorry, there was somebody talking in the background. But to deny the importance of those experiences, I think, is...
Someone who has the microphone open, but please, could you please close the microphone? Thank you.
I think I've said, Roberto, do you want to get back to me? I've been talking quite a bit there.
No, it's great. It's great. Thank you very much.
Great pleasure. Thank you.
Thank you very much.
There you are. Nice to see you. Hi.
Yes.
Okay. Now the question is allowed to speak Jean-Paul Baldacchino from Malta. Baldacchino, please, you're allowed.
Hi, thanks. Can you hear me?
Absolutely,
Yes.
Jean-Paul. Oh, very well.
Thanks. Hi, David. Thank you for a very interesting presentation. And I just wanted to follow up with two small questions.
Please.
First was an observation where you made the comments initially, and you referred to the fact that situations such as COVID, and I would extrapolate any other situation of crises, however perceived and defined, exacerbates social fissures. And I think this is an important point in coming to identify and define vulnerabilities, insofar as these fissures are already known and are already documented and quite, let's say, reproducible, I would say, from one environment to the other. There is a level of generality, if not banality, at the level of this understanding, insofar as, yes, the poor will be more affected in situations and times of crisis. So are already in situations of vulnerability will always bear more of those, the impact, and the inequalities will keep increasing in times of strain. So in a sense, these patterns are already known. I do appreciate and I get the point that the specificities of particular situations would lead to new kinds of vulnerabilities. And you've mentioned the case of the suburbanites, and you mentioned the case of the Manhattan gated community. So I do understand and get that point. But aside from that, there is a base level, a level of base humanity, where the base inequalities and the base structural, let's say, vulnerabilities will always remain affected and will always remain exacerbated. Migrant populations that are held in detention, prisoners, people who are already vulnerable by their own status. It's so in a sense it's already known and already there. And I guess I wanted to I'll just go through the other points so that then you can pick and choose what you'd like to address. But the other question was with regards to trust, and it somehow resonated with the situation, and this is where I think anthropology perhaps can step in and make its, let's say, its value perhaps more present and more known. Our previous colleague mentioned that even though Nordic countries are often cited as being countries with the highest levels of trust according to certain quantitative metrics that try and come up with a generalizable, universalizable standard of trust. Yet I could tell you that, of course, trust is one of those fascinating concepts that is itself highly culturally nuanced, and disembedding trust outside of the local context makes it completely useless. And I'm speaking, I suppose, from my own region here, and that this notion of trust has absolutely no merit and no value. If you had to try and measure trust by any of these standards, all you're going to get is an exact person by person replica of the electoral results of the last election. So obviously trust does not have the same meaning and the same understandings of what we're trying to look at when defining trust. And yet, of course, there might be something to be salvaged, or else the whole concept of trust just does not make any sense within particular contexts and situations. So perhaps this is where I obviously get a bit concerned with attempts to come up with scalable solutions, because there is ways in which sometimes the very metrics that we try to use to come up with scalable solutions do not translate. There is no scalability. There is no concept. You can try and impose an understanding of trust, but in that way you are really creating one rather than actually responding to the realities on the ground. But these are, I suppose, challenges which anthropologists can take on board.
Okay, that's for you, David.
John Paul, thank you very much. I assumed that I could count on you for complex questions. Let me respond to these because I think that they're really important. Yeah, I mean, I totally agree with you from the standpoint of accepting the fact that these fissures are already known, that they are exacerbated by crisis, and that they are reproduced and reproducible. What I think we have here is an opportunity to point this out, and by pointing it out, to suggest to those who are engaged in making decisions about the healthcare expenses and the utilization of hard-earned income from taxpayers, why it may be a better idea to invest in those problems prior to such, not engage the medical part of COVID-19 from the economic part, because the medical part costs money, and therefore the effects of the economy on our ability or our willingness to engage in the suffering of others, these are entirely interrelated and not easy to parse out or to disentangle. And so the question of how we define vulnerabilities is really quite important when it comes to being able to show that the cost, that the moral cost, and that the cost to human well-being and health are paralleled by economic costs, which are quite dramatic. And of course, we only have to think about what's happening in places where there's inadequate availability of acute care equipment because short-term interests of governments have sold that equipment off prematurely, or converted intensive care units which were sitting idle to other more efficient uses by hospital administrators. to understand that the relationship between the economic concern and the real health outcomes is quite significant. So I have nothing but agreement for your first observation. On the second one, question of trust, and of course, I've been working on a book on social trust for 5 years and written several hundred pages, but I can't say that I'm anywhere near completing it, and that's probably because of the very thing that you raise. That being that that it's very difficult to disembed trust from the local environments in which it emerges, and the ways in which people create the contracts with one another, the informal contracts hundreds of times a day that allow them to feel that their inductive assumptions about the world are going to be the same tomorrow as they presumed they were today, and they remember they were yesterday. So that experience of finding that the world isn't what you thought it was is really quite challenging. And I know I'm preaching to the choir here a bit, talking to you as a psychological anthropologist, but one of the beneficial things I think we can do is to look to the flip side of trust, which is to look at betrayal, where people not only don't trust others, but they also don't trust themselves because they did trust, or they think they trusted, and that trust was unrecognized. To see the pathological impact upon that in large-scale movements where people don't trust anyone. And of course, to me, this is one of the easiest ways of understanding the emergence of autocrats, to the surprise of many people who, if they had thought about it from the standpoint of perceived betrayal, would have perhaps seen this differently earlier on. I mean, if you look at the United States and realize that 1/3 of Americans still believe that COVID-19 was covertly created by a Chinese laboratory in Wuhan, to get a sense of the willingness of people to look for any meaning, as Nietzsche said, to take a bad meaning over no meaning, because the idea of having no meaning is completely intolerable. So for me, to conclude, I think what your point about parallels between political systems and levels of generic social trust is absolutely right. I mean, if you look at bowling alone, at the maps of bowling alone for levels of social capital in the United States, they're exactly the same as the political patterns of voting. Exactly. And so I think you've hit one very big and important issue, the nail on the head, because what the local dynamics relate to very, very long-standing perceptions about what constitutes a range of people with which one can engage in trust-enhancing activities. But of course, the problem is, in a crisis, you get things so that the lines on which those are drawn can allow people to be themselves to be taken into, rather than forced into, some ways of thinking about others that are alarmingly resemble things that happened in the 1930s that we don't need to visit today. Thanks a lot.
Thank you very much. Thank you very much. And we have some minutes for one other question, a short question. Maybe that I know that Anna Giulia Macchiarelli maybe wants to make a question. Anna Giulia?
Hello. Yes,
yes.
Here I am. Good evening, and thank you for your presentation. I wanted to ask, it's very short question because we don't have time. So I want to ask briefly, what for you is the relation between vulnerability and expandability? For example, I am doing a PhD research on the elderly during this crisis. and the elderly are already an established vulnerable group, but they became someone to be, for some people, they became someone to be sacrificed instead of someone to be protected. So I was wondering if you had any insight on this.
Wow, that's a hard question and a very important one. I can't remember the name of the US politician who actually made that suggestion that in COVID-19 we should have the elderly doing all the caring because they're going to die anyway, you know? So the question of expendability is clearly a function of who you define as insiders and outsiders, and what the actual cultural strategies are for allowing yourself to dehumanize that other, this othering process. And of course, this goes way back in structural anthropology to not just to Levi-Strauss and to thinking about people who live across the river and taking their gods and turning them into your demons, you know, the inversion of difference, but also to, I think particularly of that important essay by Edmund Leach from, I think he wrote it, must have been in the 60s, about animal category and verbal abuse, and the way in which we describe those that we want to other or want to find expendable in dehumanizing terms. And of course, there's a long history of this, and it's well documented, but I think it's something that we pay far too little attention to the way in which we use the very language that is meant to be, that we should be avoiding when it comes to those categories of people who are considered in some ways expendable. And indeed, we see this even in news reporting, when people with all the best intentions are talking about activities of the police force and so on and so forth, where those kinds of othering descriptions get repeated again and again and again. And of course, again, I would go back here to somebody I mentioned before, Mark Johnson, who I don't know well, but I do know, who wrote that wonderful book about the body and the mind, where he talked about how we use these metaphors without recognizing the power that they have, okay? Without seeing that they actually promote the very thing that we ourselves may be struggling to avoid. And so the ways in which language functions and the taken for granted assumptions that we have about it are things that we need to be really quite careful about. And of course, if we bring those metaphors to consciousness, we actually can do something about that. And I could say a whole lot about that in my book, The Age of Immunology. I interviewed a lot of patients about what's it like to have your doctor tell you that your body is at war with itself. And typically, once they think about it at that level, they try to invent other ways of describing their experience of illness because they don't like having to carry that stigma. And I think the same is very much the case for any group that society may think of as in any way not part of that increasingly smaller and smaller group of people we call insiders whenever a crisis emerges. I'll stop there because I could say a lot more about that, but I thank you for the question. It's extremely important.
Thank you, David. Thank you very much. I am very delighted for this. Your speech and your answer are really very impressive. Please let me say so. And now, I think I can give the word to Alessandro Lupo for his concluding remarks. But before, please thank again, David, and see you soon. I will follow each conference of yours starting from now.
Thank you very much, Giovanni. Thank you.
Wow.
Bye.
David, I think that you rely so much that you have produced in our audience. The density of your conference, the amount of thoughtful insights that you suggested to us is very, 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 very impressive. So I really thank you for the kind of effort you made to give us all this stuff to think about. I'm very happy that we recorded your conference, because we certainly have to see it and listen to it again and again, especially the debate afterwards. As you probably have noticed, there were many, many, many questions and very interesting ones. And I want to thank you for the very clear answers you gave, and for the very mature theoretical perspective that you have offered to us. Because obviously, when we have to think about how to do a structured ethnography in a context so difficult as the one we are in now, not being allowed to go outside and to study the very specific context where things occur, your evidence, the long experience that you have shown to us through your slides, it gives us a lot of inspiring examples and materials to think about. I think that your conference was one of the most exciting we have listened to, and I'm very glad that you accepted our invitation. You were one of the first to accept. You are the last but one, and we are really finishing with great enthusiasm for the very high quality of the interventions of the hosts we have had the pleasure to have with us. Let me just say that the very last conference we're going to have next Monday at the same time will be with Ma Zhen from the Max Planck Institute in Germany, but she's from China, and she will talk to us about fractal borders and communication in China during the COVID-19 pandemic. So I invite all of you to listen to the next conference and to listen again, because I think that today it was not enough, the time we had. You have shown us how many more things you have to say to us, and we hope to have some other occasion to listen to you, either on the internet, or if things will allow us, to invite you here in Italy in one of the conferences of the Society of Italian Medical Anthropology, or in one of our universities, so that we can know you, hug you, shake your hand, and tell you how grateful we are with you for your excellent conference. Thank you very much.
Thank you very much. Thank you very much, Alessandro. I just say in passing that it was really wonderful. I've opened my desk and pulled out a pen that says Hotel Forum Roma to take my notes. So maybe that's the sign, and I'll see you in person sooner than we think.
We certainly will see you sometime. Let's hope it can happen soon. Who knows? At the moment, we have no idea about when we'll be out of it. But Rome is a very nice place to come, and all of the Italian cities like Turin, Perugia, Venice, all of the places, Bolzano, all of the places where our audience has talked to you are wonderful places. As you know, Italy is a very, very pleasant place to visit. Maybe not so pleasant to live in. It's not as organized, but for visitors, a very pleasant place, and for visitors like you, we certainly will do our best to receive you. So thank you once again. Let's hope to see you here, or maybe in London, or wherever. And it was a really great pleasure to listen to you.
Thank you very much. All the best. Bye now. Bye-bye.
Bye-bye. Many greetings. Bye, Verona.
Bye.
Ciao, Francesco.
Ciao a tutti, grazie, molte grazie per organizzare.
Ciao Francesco, a presto.
A presto,
Bye.
ciao a tutti. Hi, bye bye.
Ciao, bye bye.
Bye, thank you.